So, as Mark mentioned yesterday, the QAAMS program has inspired our international ACE program, which is based on similar principles of QAAMS, where we use the BCA advantage for diabetes management in over 30 Indigenous communities across 7 countries, one of which is Papua New Guinea. So now I'd like to introduce Dr. Cathy Timothy, who is a doctor at Angau General Memorial Hospital, and Sheila Harou from the Morobe Provincial Government, who will talk about how they use our ACE program in Papua New Guinea. Thank you.
Thank you, Lara, for your kind introduction. Thank you to QAAMS management team for your invitation and your warm welcome yesterday. And good morning to all of you. This morning we acknowledge the Larakia people who are the traditional owners of the land we are holding the conference. We pay respect to the elders, past, present, and future. We also acknowledge or extend our respect to other Aboriginal and Torres Strait Islander people who are present. Papua New Guinea, as you know, is an island above Australia. It shares the international land boundary with Indonesian province of Papua. It has 23 provinces, one of course 22, but one is under discussion. We have over 7 million people and 800 different languages and culturally very, the country is culturally very diverse. Geography and natural terrain contributes to remoteness of majority of our population. And Morobe is where Cathy and I come from. It's this one here. And if you look at the map of Papua New Guinea, it's right here. So it's actually located right in the center of the country. And Leh is the city, capital city of Morobe province. It has a population, the province has a population of over 700,000. It's the industrial capital of Papua New Guinea, centrally located and easily accessible by most provinces. Morobe province is divided into 9 electorates, administratively known as districts. We have 33 local councils, 234 linguistic and cultural tribes. 80% of our population are all rural-based. They live in villages and hamlets up in the mountains, here. Only 20% are centered here. My role is more at the management level to secure resources to support the program.
Just a brief rundown of the disease pattern of Papua New Guinea. As presented, we are a majority of a rural population, and so you would expect more of infectious disease is highly burdened. And we see a lot of TB, HIV, malaria, pneumonia, diarrheal disease, etc. So all the infectious diseases are high on the list. But recently, our non-communicable diseases have caught up with us, the chronic diseases that most of you or all of you have talked about. Unfortunately, I don't have a good figure on our database to give on what diabetes is doing. But from the International Diabetes Federation, our figure stands at a prevalence rate of 5.4%. That was in 2013. And it's expected to actually go up. by 2030. It was estimated in 2013 that about 203,700 patients had diabetes. And of that, most of them, about 110,000, were underdiagnosed or undiagnosed. And as you can see, with that kind of trend, you would know that Papua New Guinea is really catching up with the developed world as far as the non-communicable diseases are going. Okay. And so we need a good diabetes control program in place. And that is why we are grateful that Papua New Guinea is able to collaborate with centers like Flinders International Center or Point of Care Center for us to help see how we can help improve our program back home.
Thank you. Diagnostic device for diabetes management rollout in Papua New Guinea. ACE program introduced to PNG only in 2012 through a Papua New Guinean student who graduated from Flinders University in 2011. She took the program as one of the electives while she was doing nursing studies. Since 2012, we had 2 testing sites initially established in 2 of our health centers that's in the city or town or that level. And our arrangement with Flinders, the understanding that we had with Flinders International Center for Point of Care, the understanding was for 2 years, 2012 to 2013. We reviewed that and we extended the understanding again by signing of a MOU at Flinders in January this year. We took a team of people down, there and we went through the training, the practical training, and also at the end we signed the MOU. We expanded the program from 2 sites to two new sites. That's Angau Hospital, where Dr. Cathy comes from, WAX, and one of our University of Technology. So you see this, our group of people who signed the MOU. That's Pro Vice Chancellor from the University of Technology, Dr. Cathy there, and we have a representative from the Morobe government here. And during that time, our people also went through training, and we had a good time with our friends at the International Center for Point of Care at Flinders. And when we returned, we actually had to launch the program at Angau Hospital. This one here in April 2014. Our governor is standing right here, and provincial minister for health is here. They actually launched the program at Angau Hospital. And in August, we launched the one at University of Technology, the medical clinic.
Okay, currently in Papua New Guinea, all our laboratories in the hospital don't do hemoglobin A1C or for that matter anything to screen for albuminuria. And so we're grateful that in lab we're able to do that. And as a whole in PNG, there are only 3 or 4 different sites who are actually doing hemoglobin A1C. And in Morobe, we are fortunate that we can screen for albuminuria with our VC Advantage machine. This place here is quite remote, but they were able to just get a machine. I don't think it's a Siemens machine, but whichever one they're using, they're only doing hemoglobin A1C. So this port here, or this province here, this one, and in Port Moresby, they're only doing hemoglobin A1C testing. Okay. Morobe is the only one that's able to screen for microalbuminuria or albuminuria. Having said that, our diabetes clinic in Angau or Morobe province actually was started as a diabetes clinic on its own in 2011 when I joined towards the end of 2010. I decided to start the clinic as a separate entity on its own because of the increasing number of diabetes patients that we were seeing being admitted to the wards. And so since then, up until August of this year, we've had about 300 patients who've come into the diabetes clinic and registered, of which just about 60% were male, females, and male were about 40%. Okay, and of the complications that we've seen in our clinic, retinopathy or eye disease in diabetes is high on the list, followed by amputations, peripheral neuropathy, cataracts, neuropathy, heart disease, diabetic heart disease. We also get stroke patients, skin infections. And I've sort of just put in TB because diabetes is an immunosuppressive condition in which TB can set in easily. And with our endemic TB population, TB comes in, or creeps in there very easily as well. But it's, I guess we're not seeing more of them coming through to our clinic, or maybe we don't see them in the wards often. Okay, since we started using our DCA Vantage to do our testing, we've screened about or done tests on 157 patients so far, and of which we've seen that there's more moderate to poorly controlled diabetics throughout the clinic. Okay. That's 35 and 36. And in our albuminuria screening for early identification of kidney involvement, again, there's still a lot of patients having that. If we didn't have this facility or this machine here, we would not have known that. Okay, but we're really thankful that we have the machine here. This is just a rundown of our quality checks of the machines. On the hemoglobin A1C testing or quality check, only one result had a warning level, otherwise the others were in the normal range or targeted control. And for the ACR or urine check, only 2 results were in the warning range, otherwise the others were normal. So the quality of our machine in the clinic is still good. For Unitec Clinic, they started doing the test late because of some internal problems within the school itself. But at the launching, they did, they had to, a lot of patients came in because they were curious about the machine and they wanted testing done. So that's why there was a lot of patients being tested, of which they had normal levels. Only about 6 had moderate and poorly controlled sugars. Again, for the urine screening, most of them didn't know they had some form of proteinuria or albuminuria until they came in. So I guess routine screening on patients with hypertension is what we're also trying to promote because of the pattern we are seeing, not only restricted to diabetics, but hypertensive patients too, because we also have a lot of hypertensive cases. And for the control, we've only recently used it, so the control of the machine is very good still. For the other site in Morobe that we have, the hemoglobin A1C profile, out of the 133 cases that they've tested on, there's only about 46 patients who had moderately and poorly controlled. Otherwise, the others were within good levels. Albuminuria, again, we have a lot of patients who have early kidney involvement that's been shown. And the quality control of the machines, again, still very good. Only two occasions where they were in the warning range. And this is the other clinic that we have, which showed of the 149 cases that they've tested, majority of them were normal. And for the urine as well, most of them were normal, only 13 out of the 41 had albuminuria. and the quality control for the machine. Only one occasion when it went into the abnormal range, and I think that's when the machine broke down, and we actually brought it down for the team at Flinders to actually get it replaced, and we took up a new one, so they're actually using a new one. Okay, having said that, diabetes in itself, as we can see, countrywide is still being undermanaged because we don't have all the facilities. And listening to all your presentations, your diabetes clinic setup seem to have all the different specialists that you need, whereas Papua New Guinea doesn't have that. When I mention diabetes clinic here, it's only a doctor and the nurses, and they're not specialized nurses, they're just general nurses. So I'm the only doctor who runs the clinic. So when I have other commitments and I travel, there's no one there to run the place and do all that needs to be done. So that's a big challenge for us. The other thing is frequent power interruptions is one of our main problems that we see in Papua New Guinea generally as well. We have a lot of blackouts every now and then, and most of our places, because it's still rural, we don't have electricity access to all the facilities. Okay, and doctors in the other sites, like for the 4 sites that we have the ACE program or the diabetes testing in Morobe, Guinea Clinic and Angau are the only 2 facilities that have sites that have doctors. The other 2 don't. But what we do is the nurses at the sites consult me or call me up when they have problems, so that's how we manage our patients together. And as I've said, because I'm an internal physician, internal medicine general physician as such, I do all other work as well. So I don't just stay at the diabetes clinic and manage diabetes patients alone. So with the rising number of diabetes patients, I definitely need another person to be trained as well, and another doctor to be with me at the clinic. So I guess with the training, I'm sure Lara and them will help us to train some operators for Papua New Guinea. And on that note, I think our program here, the ACE program, and the use of the machine has gone to the national department level, and we are happy that, you know, before I came down, one of our non-communicable disease manager at the national level had to whisper into my ear that they were thinking of getting some of these machines for the other facilities. So that's actually a way forward for us, and I'm thankful that we're able to come to this kind of workshops to learn more and at least help to improve the care of diabetics in Papua New Guinea. Okay, so for our acknowledgement, we really want to acknowledge Professor Mark Shepard and Lara Mota, and as a whole the QAAMS management for inviting us and for being part of this workshop for these 2 days. I also would like to personally thank the Morobe provincial government because of the funding to bring us down here, and the whole program of ACE rollout in the country is actually being supported by the Morobe provincial government through Sheila, who is very instrumental in moving this program forward. So thank you very much.
Thank you. Just quickly, we have a long way to go, as you have seen in the presentation, but we have taken the first steps, and we are happy that we have taken the first steps, and we will see how we go with all of your support. At this note, we have a small gift here. We would like to, as a token of our appreciation, we would like to call on the National QAAMS leader, Chris O'Brien. Organic coffee. We also call on Siemens International, who are also our partners, who's been supplying us consumables and the device and so forth. We've only talked to them over the phone and also through email exchange, and we are pleased to meet with them today. Sue, standing please. Thank you. I think we end here.
Well, thank you very much, Sheila and Dr. Cathy. It's a pleasure to have you as part of the ACE program, and really pleased that you're able to come to the QAAMS workshop and experience what we're doing here in Australia with Advantage, and to meet so many of the QAAMS participants. I'd also very much like to thank all of the participants in this session. We've had 5 really interesting and humorous, particularly in the case of Cheryl's presentation. So thank you very much for all of the time and effort that you put into your presentations and in delivering the presentations. I think, I know, pardon me, I enjoyed every one of them, and I hope all the other participants did as well. So can we have a thanks for everyone, please?